Thank you again, David, for inviting me. It's a real pleasure to be in Zagreb. I have a long time connection with, in fact, already with Yugoslavia and later with Croatia and Slovenia. And I will talk a bit about the history and where we are now, the latest, let's say, publication studies, and how we have changed our practice because of these studies and publications. So, stroke, you all know, is one of the most debilitating diseases. These are figures from a few years ago already, and we know that with the people getting older, you will see more patients with stroke, and it is a huge burden of disease worldwide. So that's the reason that we should look, how do we treat those patients? And the treatment is only very recent, because I think if you look 30 years ago, before that period, there was hardly anything. The only thing you could do was pray and put patients in a bed. There was no real treatment, and that changed by 1995, because at that time the trials that showed that intravenous thrombolytics were beneficial for those patients were published, and since then, intravenous thrombolysis is the standard treatment, first treatment, if there's no hemorrhage in the brain. So that was in 1995. Then we had some treatment, but still this treatment, you had to do it very fast, within 4.5 hours. In fact, in 1995, within 3 hours, later extended to 4.5 hours. But you had to do it in the early hours, and else it was not successful, not beneficial. And in the larger vessels, the most devastating strokes, it was not, well, successful at all, or hardly did anything. So in the same time, physicians were looking for alternatives to especially address these large vessel occlusions, the most severe strokes. And mechanical thrombectomy came in that place. So you had to go to the angio suite, and then this is a movie, if it works. Let's see. So this movie shows a bit an animation how it works for those who are not familiar with it. I thought there's a mixture of physicians here, both neurologists, interventionists. This is the standard way we do it. We did it in those trials, the early trials. You place a stent retriever, a stent in the clot. You open the stent retriever, or it opens by itself, self-expanding, and then you have already a little flow, and then you take out this stent retriever, opened in an open configuration, and you pull it out together with the clot. That's the idea of a thrombectomy. And then this is what you see before. You have an occluded middle cerebral artery here, and if you open it, you will have these results, and you take out these clots. This is the idea of the thrombectomy nowadays, and that is, well, let's say successful since 10 years, because it's 10 years ago that the first publication came out, and we keep on celebrating this event, that 10 years ago we had the first publication. There were, next to the Mr. Clean More studies, this is the way we usually present the outcome, the clinical outcome of these patients. So the MRS score, I think you're familiar with it. MRS 6 is dead mortality, and MRS 0 is no symptoms, and everything in between, what you can see above. And if you have a shift to the right, the upper bar, then it means there is success. You have more patients in a good clinical condition, finally. And that was what we clearly showed in Mr. Clean, but not only Mr. Clean. There were several other trials. They all stopped when we presented our data, because they looked into their own data, and they all saw the same result. They all saw the same benefit of endovascular treatment. So since then, it's really established. We pooled the data of these trials in the so-called Hermes collaboration, and there you see again this shift. Now the bottom line is the intervention line, shift to the right, with a number needed to treat of 2.6, and that's quite spectacular. This is a very successful treatment. If you compare it with, one of my colleagues did with other trials, even with PCI in cardiology, the number needed to treat here is even lower. So it's a very, very successful treatment. You save a lot of quality of health, not only lives. The mortality does change, but it's mainly that you change the quality of life. So you keep patients out of rehabilitation centers. So the guidelines in 2015 were immediately updated. So this is the American Heart Association guidelines. They stated you should offer those patients with large vessel occlusion endovascular treatment. But all those trials were in the anterior circulation. So the guidelines state ICA, internal carotid artery, or middle cerebral artery occlusions. For those occlusions, large vessel, these data were valid. Now, very recently we saw that also in basilar artery occlusions. It is only 10 to 15% of the ischemic strokes, but still it's a severe disease if you have an occlusion of your basilar artery. And before, this is 2019, before 2022 in fact, there was no real evidence that you could do with a success basilar artery occlusion thrombectomies. And that changed recently, what you can see here, 2020 to 2022. There were 4 trials, randomized controlled trials, that not all showed a benefit. The basics, organized from the Netherlands, was the first one, did not show a significant benefit. I don't want to go into details. They show, well, it seemed there was a benefit if you had an NHSS, a severe stroke, NHSS of more than 10. But if you had very mild strokes, then in basilar artery occlusion, the endovascular therapy was not so beneficial. Later trials showed a clear benefit. And if you combine those 4 trials, and that's what has been done recently, early this year in the Veritas collaboration, you see that there is the same, more or less same shift on these bars to the right for the treatment. So there is definitely a benefit. But if you look at the subgroups, and again, below 10, NHSS of 10, so the stroke score less of 10, which is mild strokes, there seems to be no benefit. And that's why in the guidelines, we recently updated the guidelines end of last year. We state that endovascular treatment in basilar artery occlusions is beneficial, but only for an NHSS of more than 10. And whether 10 is the right cutoff point, I don't know. It can be 8 or 9 or could be even higher, but anyway, very mild symptoms and a basilar artery occlusion. We in our hospital tend to wait, put a patient under very close surveillance. If he deteriorates, there's still a reason to treat, but usually we just leave them and we watch them. Another thing that we saw, you probably know that in all those trials, the stent retriever, as I showed you in the beginning, were the treatment techniques that we used. But in the same time, aspiration was another technique that was used. You either use a syringe here or a pump. You have a large bore catheter that goes all the way to the clot and you aspirate the clot. And if you combine that with a balloon guide catheter in the proximal part, in the carotid artery, then here they call it badass technique. But these are modifications of a technique. So here's aspiration together with a stent retriever and then proximal balloon guide, and they say this is the best technique. Anyway, what we found in the guideline committee, in the literature, is that if you look at the studies that compared stent retriever with aspiration in the basilar artery occlusion group of patients, there seems to be a benefit for aspiration first. So we put it in the guidelines. We put this in the European Stroke Organization guidelines that for basilar artery occlusions, it might be better to start with aspiration first. Okay, that about basilar artery occlusions. Now, what about the more distal occlusions? As I showed you, internal carotid artery, middle cerebral artery, first segment, those were in the guidelines, the ones that you should treat with endovascular treatment. But the more distal ones here, they call it the medium vessel occlusions, the M2, M3. Many studies, mostly organized by the industry, that designed special small stent retrievers or small aspiration catheters, they showed in their studies that there is a benefit if you treat those distal occlusions with their devices. But then, of course, you need a randomized trial. All those industry-organized, initiated studies seem to be positive, but you need randomized trials. And there were several started in recent years. I just gave here an overview. These are 7 studies, but 3 of them have ended now, 2 already published, and a 3rd one presented. And I show you very short those studies. Distal is the one from Switzerland where we participate. It's an international study. We participate in that study. They presented it at the International Stroke Conference in Los Angeles, and at the same time they published it in the New England Journal. No benefit. In fact, there is no significant benefit from the treatment, endovascular treatment, if you compare it with just standard medical treatment. The other one, Escape Mevo, organized from Canada, Calgary, also international multi-center. Same result. No significant benefit. You don't even see a trend. Well, yeah, maybe there's a trend in the other direction if you look at the higher ranges, but there is no significant benefit at least. And then the last one, that's the discount. Now it works. So this is the discount from France, and here you see even that there's a significant outcome, p-value, but to the wrong side. So the endovascular group did worse than the best medical treatment. So distal occlusions, I don't know. There's no benefit. You can say don't do it. We had in a recent iCure conference in Istanbul last week a lot of discussions about these distal occlusions. Some say there were many flaws in those studies, we should look at subgroups. But even if you look in those studies at the subgroups, there's no signal that there's a subgroup benefiting from this treatment. So, and others say, yeah, the technique was not right, but we have those small devices already. So I don't know. There's one of the PIs of distal that said, well, the technique is not good. You should use a kind of quattro technique. This is what he promotes. I showed you the badass technique, but this even adds another more distal aspiration catheter. So you have two aspiration catheters, a balloon guide and a stent retriever, and this then should be better for those distal occlusions. I don't know, but we don't see any signal yet. Another thing we looked at in recent years is in the late window. All those earlier trials were within 6 hours. Why within 6 hours? Here's an example from our own Mr. Clean trial. You see that the treatment benefit, which is here the odds ratio, the treatment benefit disappears over time, and after a bit more than 6 hours, the treatment benefit was not significant anymore. So there is a rationale to say, okay, this should be done within 6 hours, at least then we have evidence. But you also know probably that some studies selected patients based on advanced imaging, CT perfusion, MRI, and with a certain selection, they found a significant benefit of the treatment even after 6 hours. These are those criteria that they used. Not that strict, I mean, quite large core that they accepted still, but you had to select patients based on this advanced imaging. And very recent, we did the Mr. Clean late trial, and there we only selected on the presence of collaterals that you can see on CTA. So you did not need to do advanced imaging. And we even excluded those patients that fulfilled already the criteria of the other trials. So this is an extra group of patients with still collaterals available, and it's published in 23. And again, we see a benefit. So even if you only select on the presence of collaterals, you can treat those patients in the late time window. So we get more and more liberal in treating patients in the late time window, basal artery occlusions, etc. The relevance of this study was that you can treat more patients and it's easier. Many countries where they don't have perfusion or MRI available or have no experience with it, they can use this algorithm looking at collaterals and treat those patients in the late time window, so they can treat many more patients. Similar thing happened. I want to go back to intravenous thrombolysis. That was, as I said, within 4.5 hours. But this is the recommendation from 2021. Within 4.5 hours, you should treat those patients with intravenous thrombolytics. But also here, a similar change happened. You see those two trials, the Wake Up trial and the Extend trial, they showed if you select patients, either on MRI or perfusion imaging, in the late window you can still give IV treatment as well. So the recommendation in our guideline changed. Now you can treat patients, and here they say up to 9 hours of mid-time of sleep, mostly about wake-up patients. You can treat those patients if you select them on CT or MRI criteria, as in the study. Another question then, Should we give this IV treatment still if patients already are selected or eligible for endovascular treatment? You go to the angio suite. Should you give IV treatment before? Well, this question has been addressed by 6 studies together at the same time, all published, and they pooled again their data in this IRIS collaboration. And what they wanted to show, that you can skip IV treatment if you go for endovascular treatment. And they call that it's non-inferior if you leave it out, IV treatment. They could not establish this non-inferiority, meaning that there's potentially still some benefit of IV treatment. So the guidelines were not changed. In fact, they could not show that you can leave IV treatment out if you go for endovascular treatment. And here the guidelines, both European and American guidelines, they still keep IV treatment as the recommended treatment, even if you go afterwards for endovascular treatment, or even if you go directly through to your angio suite for endovascular treatment. All those studies comparing IV treatment before endovascular treatment with no IV treatment were done in the early window, the standard window for IV treatment. But the question now is, when we're talking about late window, should you still give IV treatment before endovascular treatment after 4.5 hours? Because then you need this advanced imaging to give IV treatment. Well, the guidelines do not give a recommendation. They don't know, no consensus. But in this IRIS study recently, they showed that this IV treatment before you go for endovascular treatment is also time dependent, and in fact only significantly beneficial within 2.5 hours. After that, there might be some benefit, but definitely after 4.5 hours, and I showed it here, depending on the minimal clinically important difference of 5% or 3%, that's a clinical term that they use. You can say that after 4 hours, there is no benefit anymore of IV treatment before endovascular treatment. So in this late window, where you have to do advanced imaging for IV treatment, you can skip it if the patient goes for endovascular treatment. And that is exactly what we have already incorporated in our hospital. And I show you, it's in Dutch, but the chart that we use in our hospital. So, and I use here first 4.5 to 6 hours, because up to 6 hours you don't have to do anything for endovascular treatment either. You don't have to look at collaterals or anything else. So after 4.5 hours, if you see an occlusion here, you go directly for intra-arterial treatment and you skip the whole IV treatment. So we skip IV treatment after 4.5 hours if the patient goes for endovascular. And after 6 hours, you have to do some extra for endovascular treatment, but we look at collaterals. So if there's an occlusion, we skip IV treatment. We look at collaterals. If there are collaterals, we go for intra-arterial treatment. If there are no collaterals, you can still look at perfusion imaging if you want to do that. But usually, if there are no collaterals, then the perfusion imaging is negative, I would say. So usually we look at collaterals, and then if there are no collaterals or if the patient is not eligible for intra-arterial treatment, then we go for intravenous thrombolytics if they fulfill those criteria. So this is now the way we work. We skip IV treatment in the later time window after 4.5 hours if patient goes for endovascular treatment, and we select on collaterals for endovascular. Okay, now then for IV treatment, if the patient doesn't go for endovascular, you should still use advanced imaging. But should we still do that? And here I wanted to show you that this group of late window patients are mainly wake-up patients. Most of those patients wake up with a stroke. More than 50% of those, let's say, late window are wake-up patients. And what we recently learned is that those wake-up patients, mostly, I won't go into detail, but they have their stroke just before waking up. In this publication, they try to show that about 90% have their stroke within 1 hour of waking up. So in fact, if they arrive fast in the hospital, they are not late window. And then if you select those patients on advanced imaging, you will run into a trap because you can have false advanced imaging. I think you should consider them as early window patients. That's my idea here that I wanted to present to you. We don't have real evidence yet. It comes from all kinds of secondary studies. But for me, those wake-up patients are early window patients. Don't ask for the last known well time. That's always the evening before. It's always late window then, but the majority wake up just after having stroke. Okay, that's another thing. That's my personal opinion, and I want to find out if that's really true. But in the meantime, we work like this. We look at the time they wake up. Another thing, very recently, we look at the aspect score. In the early guidelines, they always say a low aspect, that means a large area that is already affected by the stroke, you should not treat them. Now, very recently, there were many studies. These are the first 4 that show that if you have a low aspect, so a large area already affected, there's still a treatment benefit. Same as in the other studies, there is significant treatment benefit. Of course, high mortality, outcome is not good, but there is a treatment benefit. And another study that came later, they said they did not show significant benefit, but in fact you see the same shift. Mortality didn't change, but in the thrombectomy group the outcome was better. It just confirms the other trials. And most recent study is the last, and they included patients with even an aspect of 0 or 1. The others did from 2 to 5 or 3 to 5. And 0 or 1, that means the whole middle cerebral artery territory is affected by the stroke at that moment. And we, for a long time, thought there is no benefit in these patients. But also this study is positive. And more important, there is no difference in the below 3 aspects and the 3 to 5 aspects. So, in fact, it means that you can treat those patients with low aspects as well. If they have already an affected area on your CT scan, that doesn't mean that the whole brain, well, is lost and you shouldn't do anything. There is still a benefit, although the outcome is bad in general. All right, that's the whole story from 10 years ago to now, and still studies are ongoing. We look at tandem occlusions, we look at many other things still, but this is what we have seen in the past 10 years. So the treatment, yes, definitely is very effective. One of the most effective new treatments, I would say. Also for basal artery occlusion, so not only for the anterior circulation, also in the late window, and selection should be very easy. Some even just look at a plain CT scan and say if there's not a large area affected, we treat those patients. But I think we could be very liberal in treating those patients. And also patients with already a large area affected. In MEVOs, so the more distal occlusions, it's more doubtful. Probably the effect is not so big, and probably if we want to have an effect there, we should look in how should we change it. Should we improve our treatment? Should we change or should be more selective? I don't know yet, but it seems that there's no overall benefit in those treatments. And then another thing, skip IV treatment. If the patient will go for endovascular at least beyond 4.5 hours, within 4.5 hours, there seems to be still a little benefit. And the last thing I wanted to give to you is forget about last known well in those wake-up patients. Just start counting when they wake up, because that is the time, or just before that, they had their stroke, and then do the same as you always do in your hospital. I think that is a bit of an overview of what we have done in the past 10 years. Are there any questions at this moment?